Welcome, everyone, and good afternoon. Thank you for joining NCBA and the Michael J. Fox Foundation for Parkinson's Research for our webinar today on Parkinson's disease in the Black and African American community and the importance of research participation. Our presenter for our webinar is Alyssa N. O'Grady. Alyssa joined the Michael J. Fox Foundation for Parkinson's Research, MJFF, in 2015. In her current role as Director of Clinical Operations, Alyssa is responsible for establishing the long-term vision, setting strategy, and achieving strong execution of MJFF-sponsored clinical studies, including MJFF's flagship natural history study, the Parkinson's Progression Markers Initiative. She is also responsible for the direct functional management of specific study and patient engagement teams within MJFF. She is a key contributor towards realizing MJFF's mission through developing and managing high-impact flagship clinical studies that advance therapeutic development for global patient value. And Alyssa is a founding member of the Internal Diversity, Equity, and Inclusion Task Force at MJFF. She graduated from Harvard College with a BA in chemistry, and her educational background is in organic synthesis. Also, who will be assisting today is Maddie Cutler. Maddie Cutler joined the Michael J. Fox Foundation for Parkinson's Research in 2021. In her current role on the patient engagement team, Maddie supports recruitment and retention for MJFF's flagship natural history study, the Parkinson's Progression Markers Initiative, PPMI. They are also responsible for several diversity, equity, and inclusion community engagement projects to help with the study's goal of increasing the number of participants from historically underrepresented communities. Maddie graduated from the University of Southern California with a BA in psychology and a BA in French. Their educational background is in LGBTQ+ public and mental health, and French post-colonialism. So thank you, Alyssa. We appreciate you joining us today, and the floor is all yours. Thank you.
Thank you so much for the kind introduction, Angela. Very excited to be here chatting with you all, and also want to thank my colleague, Maddie Cutler, for taking care of these slides for me. As Angela said, my name is Alyssa O'Grady. My pronouns are she and her. I have been at the Michael J. Fox Foundation for Parkinson's Research for 8 years, and I'm currently serving as the Vice President of Clinical Research. I lead a team that shares best practices for making Parkinson's disease clinical trials smarter, faster, and cheaper, which will help accelerate the development of new treatments for Parkinson's disease. Before I dive into the slides, I wanted to share with you my 3 goals for today, the 3 things that I want you all to walk away with. First is that I want you to all walk away with a better understanding of what Parkinson's disease is and how it impacts the Black community. Second, I want you all to understand where you can go to get more information about Parkinson's disease and research so that you can best support yourself if you are dealing with Parkinson's disease, or if someone you know and love is dealing with a Parkinson's diagnosis in their family. And third, I want you all to walk away with an understanding of what you can do today to contribute to our search for a cure for Parkinson's disease for all. With that, I will move to my first slide and get into the meat of the discussion for today. So starting off, I wanted to give a brief introduction to the Michael J. Fox Foundation for Parkinson's Research, or MJFF for short. MJFF was founded in the year 2000 by, of course, the actor Michael J. Fox, and our vision is a world without Parkinson's disease. Our mission is to advance new treatments for people living with Parkinson's disease today and to ultimately find a cure for Parkinson's disease that is accessible to all. Once we've reached that point, we aspire to go out of business, to shut our doors and say that our work is done, we've cured Parkinson's. We are definitely keeping our eyes on the prize of that very lofty but very important goal. We execute our mission by funding research. We are the largest nonprofit funder of Parkinson's disease research in the world, and we have funded over $1.5 billion in Parkinson's disease research to date. And everything we do is guided by a focus on patient centricity and patient value. And for patient centricity to truly be successful, we believe that it must include diversity, equity, and inclusion. Next slide, please. So what is Parkinson's disease? Parkinson's disease is a progressive neurodegenerative disease. So breaking that down a bit, progressive means it gets worse over time. Neuro means it's a disease of the brain. And degenerative means that you're losing something if you have Parkinson's disease. In the case of Parkinson's, it means you are losing a cell in the brain called dopamine, and that cell is responsible for regulating movement and other bodily activities. So when dopamine is decreased in the brain, like we see in people with Parkinson's disease, it causes the presentation of motor symptoms and other dysfunctions that we'll talk about in a few slides. There are more than 6 million people living worldwide with Parkinson's disease and about 1 million people in the US living with Parkinson's disease. And it's the second most common brain disease after Alzheimer's. 1 in 100 people over the age of 60 have Parkinson's, and some folks may be diagnosed at younger ages, at 40 or younger. I also wanted to say that Parkinson's is unique to each person. We have a saying at the Fox Foundation that if you've met one person with Parkinson's, then you've met one person with Parkinson's. The way that Parkinson's disease presents in each person looks very different, and everyone's journey with Parkinson's looks different. We don't exactly know why PD or Parkinson's disease looks different in each person or how to reliably predict what somebody's progression of symptoms will look like, but MJFF is supporting much research to try and define and predict the different subtypes of disease. I did also want to double click on the relationship between Parkinson's disease and Alzheimer's disease, since many folks are often more familiar with Alzheimer's than they are with Parkinson's. Parkinson's disease can lead to memory and thinking issues, especially in later stages. However, Parkinson's is clinically characterized more so by issues with movement, like tremor, slowness, stiffness, issues with balance and gait, whereas, as most people know, Alzheimer's disease is clinically characterized by the issues with memory and thinking. Next slide, please. So we have a couple of poll questions to get you all talking in the chat a little bit. And the first one for you all to respond to is there anyone in your life who has Parkinson's disease? You can enter your response in the chat. Seeing some no's. We've got one yes in the chat. So a little bit of a mix, but skewing towards no. Glad to see that you are all still interested in this topic, even though you may not know anyone with Parkinson's disease. We will certainly talk about healthy aging and brain health over time, topics that are really applicable to all. And then if you do have someone in your life who receives a Parkinson's diagnosis, then I'm hoping you'll have lots of great information today that you can take away with you to best support them. Next slide, please. We've got another poll question. Is there anyone in your life who has Alzheimer's disease or other neurodegenerative diseases? So as I mentioned, Alzheimer's disease and Parkinson's disease, although they are both neurodegenerative diseases, are quite different, especially at the early stages, but they do have some things in common. Both Alzheimer's disease and Parkinson's disease have something going wrong in the brain. They are actually both characterized biologically by the buildup of protein in the brain. You've got one type of protein that causes Parkinson's and another that causes Alzheimer's. And we in the Parkinson's space are always looking across the aisle to see what's going on in the Alzheimer's disease research and care space, to see what we can learn from Alzheimer's disease research, and also what we can share with Alzheimer's disease researchers to help them. Diane, I'm very sorry to hear that. It is really challenging to see someone in your life suffer from Alzheimer's disease. My thoughts go out to you. Well, thank you all for sharing your responses in the chat. Next slide, please. So I've touched on this a little bit already, but I can share a little bit more about what Parkinson's disease looks like. It's really a constellation of symptoms. Many people think of Parkinson's disease as a motor disease, and it certainly does have sort of classical symptoms of motor dysfunction. But there are also many non-motor symptoms that sometimes can even be more bothersome to people with Parkinson's than some of the motor symptoms. On the left side of the slide, you can see some of the motor symptoms that are associated with Parkinson's disease. One is a resting tremor, where you may see somebody's hand or foot shaking, slowness of movement, rigidity in their posture, and issues with balance and gait or walking. Then on the right side of the slide, you can see some of the non-motor symptoms of Parkinson's, which can include cognitive dysfunction. It's not particularly common in the early phases of Parkinson's disease, but as the disease progresses, there can be issues with cognition, memory, and thinking. Depression and anxiety are amongst the most highly reported non-motor symptoms of Parkinson's disease. And they can also be quite underreported because of the stigma of talking about depression and anxiety. Constipation and digestion issues. I think your typical person who may not know that much about Parkinson's disease may be surprised to hear this, but we actually hear from patients all the time that they had issues with constipation long before they ever had a tremor or received a diagnosis of Parkinson's. It's actually quite common. And then sleep disorders, disruption to normal sleep patterns. Many people with Parkinson's experience something called REM sleep behavior disorder, which is a disorder where you act out your dreams while you're sleeping. And that is another symptom that can happen during Parkinson's disease, but is also commonly reported by patients as something that they experienced before they received their diagnosis of Parkinson's. Next slide, please. How is Parkinson's disease diagnosed? So there is actually no singular objective test to test for Parkinson's disease that would lead to a really definitive Parkinson's disease diagnosis. Today, Parkinson's disease is diagnosed by a clinical exam. So what that means is it is a doctor's interpretation of the visible symptoms that a doctor can see. Another way that Parkinson's is often diagnosed or confirmed is response to Parkinson's disease medication. We'll talk about the medication on the next slide, but there is a commonly prescribed treatment for some of the symptoms of Parkinson's disease. So if a doctor sees someone who they think may have Parkinson's, one method for confirming the diagnosis is to prescribe this medicine and see if the person gets better. If they do, then they deduce that that person likely has Parkinson's disease. It is actually a huge problem that there is no singular test, singular objective test that exists for Parkinson's disease, because that means you are relying on something that is imprecise, somebody's subjective opinion of just the symptoms that you can see. And that leads to late diagnosis, and it also leads to misdiagnosis. If you don't have something completely objective to tell you if somebody has Parkinson's or not, what we'll see sometimes is somebody may start with a Parkinson's disease diagnosis, and then as their symptoms progress, it turns out that that person may actually have a different neurodegenerative disease disorder. There are a few diseases that can sort of look the same in the early stages. So the Fox Foundation is highly invested in developing and accelerating the development of objective measures for Parkinson's disease. And I'll talk more about that when we get into some of our research participation opportunities later in my presentation. But before we get there, I did want to share that we do have an objective tool that can at least help us confirm a Parkinson's disease diagnosis. So you can take a doctor's subjective opinion on if someone has Parkinson's disease, and you can confirm it with a technology called dopamine activity transporter scan, or DAT scan for short. DAT scan is somewhat similar to an MRI scan or a CAT scan, if you've ever had one of those. And it is specifically looking at dopamine activity in the brain. Again, dopamine is the cell type that is lost when somebody has Parkinson's disease. There is a diminishing of dopamine in the brain. You can see from this picture here, on the right side, you have the DAT scan of a person with Parkinson's disease. On the left side, you have a DAT scan of somebody who does not have Parkinson's disease. And the lit up portions with the yellow, the pinkish color, and the bluish color, that's showing you how much dopamine activity there is. You can see in the person who does not have Parkinson's, you have much bigger spots and much brighter spots with more yellow. And then for the person who does have Parkinson's, smaller spots with less of that yellow and less of that pink color. So DAT scan is an incredible tool that we have at our disposal, but it's not enough because it is very expensive, and it is often not available outside of academic research hospitals. So we are driving towards more accessible and more robust measures of disease to aid in diagnosis and ideally also aid in the tracking of progression of the disease. And again, we'll come back to that concept a little bit later. Next slide, please. How is Parkinson's disease treated? So all of the current treatments for Parkinson's disease are focused on treating the symptoms of Parkinson's and lifestyle changes that can help make dealing with the disease easier for somebody with Parkinson's disease. The most commonly prescribed medication for Parkinson's is a medication called levodopa carbidopa. You may also hear it called by its brand name, which is Sinemet. Many people with Parkinson's take levodopa carbidopa for relief from symptoms of like tremor or stiffness and slowness, really the motor symptoms of Parkinson's disease. And then for the non-motor symptoms, something like depression or anxiety, Parkinson's disease doctors will treat those symptoms using pretty much the same therapies that they would use to treat depression in somebody without Parkinson's disease. So there are certainly treatments that offer relief to people with Parkinson's and can help people lead a good life and a healthy life with Parkinson's disease. But because it is a progressive disease, a disease that gets worse over time, there typically comes a point where the oral medication, levodopa and carbidopa, may not be enough to help control someone's symptoms. That's when individuals might seek some elevated levels of care and treatment. There are surgeries that can help with the symptoms of Parkinson's disease. So surgery called deep brain stimulation, where electrodes are implanted in the brain and they're able to emit a signal that helps restore normal motor function. There's also a technique called focused ultrasound that creates benign lesions in the brain that also can help with some of the motor symptoms. And then finally, pretty much every doctor who's treating Parkinson's disease is going to strongly recommend that you exercise regularly to help with your relief of your motor symptoms, that you have a healthy diet, and that you seek out social support. As I mentioned, non-motor symptoms of Parkinson's can include things like depression and anxiety. Those symptoms are worsened if you are isolated and if you are not seeking out a network. So social support is incredibly important for everybody and definitely very important for people with Parkinson's disease. All of these treatments, as I mentioned, they do focus on relief for the symptoms of the disease, but some of the unmet needs for people with Parkinson's are treatments for the non-motor symptoms. We have some options, but they may not all work for everybody. And most importantly, a treatment that can impact the underlying disease with the goal of stopping or slowing the progression of the disease. We do not have a treatment that is like that is available. That to us would be a cure. That to people with Parkinson's, we have been told would be a cure. And we continue to support a lot of research to try to get us to that holy grail, that cure, so we can have our world without Parkinson's that we envision. Next slide, please. A question that we often get asked is, how do I know if I'm at risk for Parkinson's disease, or what causes Parkinson's disease? So there's no single known cause for Parkinson's, but we do know that there are some factors that may put people at a higher risk for developing Parkinson's than others. And before I talk about any of the risks, please note that having a risk factor for Parkinson's does not guarantee that you will develop Parkinson's. It just does put you at a higher risk for potentially developing the disease over time. So on the left side of the slide, we have some of the well-known risk factors for Parkinson's. One is getting older. Parkinson's is a disease of aging, so we know that as you get older, the likelihood that you will develop Parkinson's disease increases across the board for everybody. Second is having a first-degree family member with Parkinson's. So this would be a parent, a child, or a sibling with Parkinson's disease. There are some specific genetic mutations that are associated with higher risk for Parkinson's, but even if you do not carry one of those genetic mutations, you may be at a higher risk for developing Parkinson's if you have a first-degree family member with the disease. As I just mentioned, carrying a Parkinson's genetic mutation puts you at a higher risk for Parkinson's disease. And then serving in the military and being exposed to environmental toxins, both may put somebody at elevated risk. This is for the environmental exposure issue. And then with serving in the military, there's also the risk of traumatic brain injury or persistent concussions that may happen as part of combat. Those types of brain injuries put somebody at a higher risk for the disease. And then on the right side of the slide, I wanted to mention a couple of the sort of early signs that somebody may be on the way towards developing Parkinson's disease. Again, just because you have either of these things does not mean that you will get Parkinson's. But through studying large numbers of people with Parkinson's and people who we believe to be at risk for Parkinson's, studies show that a sustained loss of sense of smell may be an early symptom of disease or something that shows that someone is more likely to develop Parkinson's, as well as REM sleep behavior disorder, that disorder of acting out your dreams while sleeping. Okay, that's all for here. Next slide, please. So now we're going to shift gears a little bit. Hopefully you have more of an understanding of what Parkinson's disease is overall. And now I want to talk more specifically about Parkinson's disease in the Black community and disparities in access to care and in participation in research. So our next poll question here, if you were to guess, how much less likely are Black and African Americans with Parkinson's disease to see a neurologist? So looking for a percentage here. How much less likely are Black and African American people with Parkinson's to see a neurologist over non-Black and African American individuals? Seeing 70%, 10%, 50%. Mhm. Thanks for your guesses, everybody. Okay, time for the big reveal. Next slide, please. So Black and African American people with Parkinson's are 30% less likely to see a neurologist. That means that Black and African American people with Parkinson's disease are not getting the best care that they could get if they're not seeing a specialist, a neurologist, or even better, a movement disorder specialist, which is a neurologist who's done an additional training in movement diseases like Parkinson's disease. There are some reasons why we think Black and African American folks are less likely to see a neurologist, and there are also some implications. So one reason is previous studies have shown that Black and African American folks are more likely to perceive Parkinson's symptoms as part of normal aging, and therefore less likely to seek out treatment for any of those symptoms. And then in terms of the impact, it means that Black and African American folks are diagnosed at later disease stages, are less likely to be diagnosed overall, and are less likely to receive treatments and advanced levels of care than white counterparts with Parkinson's disease. Next slide, please. So what does Parkinson's look like in the Black and African American community? I often get asked, is PD, Parkinson's disease, more or less common in the Black community than it is in other communities? Or I may get asked, does Parkinson's present differently in Black people than it does in non-Black people or white individuals? So the short answer is we don't know for sure, because there is underrepresentation of Black folks in Parkinson's disease research, a concept that we'll come back to in a few slides. But we do have some studies that have looked at this. Some studies agree on what they found, and then some studies actually have conflicting results. But based on the information we have, it does seem like Parkinson's is slightly less prevalent in the Black community. However, this is likely an underreporting issue and not an actual fact that there are fewer Black individuals with Parkinson's disease. We just don't have enough data to be able to reliably make that conclusion. And then some studies have shown that Black folks are, because we are more likely to have vascular disease, that may lead to a worse prognosis, a worse progression of the disease. Black individuals may have a reduced response to medication and earlier onset of dementia in Parkinson's. Some studies have shown higher rates of cognitive decline and progression of dementia, and a slightly higher mortality rate. But I would say take all of this with a grain of salt, because if you are only looking at a narrow slice of Black individuals with Parkinson's disease, and you are undercounting and not asking everybody who you can, who is Black and has Parkinson's disease, what their experience looks like, then you're not going to get the full picture of what the Black experience is with Parkinson's disease. So in our next couple of slides, we are going to double click on this concept of underrepresentation in research, and we can move to the next slide and our next polling question. So if you were to guess, what percentage of Parkinson's disease studies report race and ethnicity data? So of all research studies that are being done in Parkinson's disease, what percentage even report on the race, ethnicity, demographics of the people in their studies? 15, 0, 50, 30. We've got some great guesses here. 10%, 70%. All right, again, let's go for our big reveal. Next slide. So only 17% of Parkinson's studies conducted between 1985 and 2007 reported on race and ethnicity data at all. So we're limited in what conclusions we can draw, because only 17% of studies have that information available. But when looking at those 17% of studies that did report on race ethnicity data, only 6% of participants in all of those research studies were non-white. So you could imagine that an even smaller percentage of individuals in those studies were Black or African American. So suffice it to say is there is very low representation of Black and African American folks in Parkinson's disease research. And again, that means we are not getting the full picture of the Black Parkinson's disease experience. So let's talk a little bit about why Black and African American folks are underrepresented and in many cases historically excluded from Parkinson's disease research studies on our next slide. So there are many reasons why Black folks are underrepresented in research, and I would be remiss if I did not start by acknowledging the historical mistreatment of Black research subjects. And I use the word subject here very intentionally. Today at the Fox Foundation and elsewhere, when we are talking about ethical research with informed consent, we call the individuals in our studies participants or volunteers because we are ethically obligated and want to make sure that everybody who is in our studies wants to be there and knows what they are signing up for. That was not the case with the historical injustices listed on this slide, the Tuskegee syphilis study, Henrietta Lacks' cells, and the James Marion Sims surgeries. Those were instances where Black folks were being treated as subjects. They were abusive, coercive, and inhumane studies and cannot be repeated. But the impact of these studies is that there is certainly a mistrust of physicians and in the overall research process amongst the Black community that persists to this day. These instances were so horrific that their ripple effects are still being felt today. Next slide, please. So in addition to some of the historical mistreatment of Black research subjects and the mistrust that has led to, MJFF also supported a study to understand what are the other barriers to research participation in the Black and African American community. And we supported the study because the first step towards resolving those barriers, for breaking down those barriers, is to really understand what they are. So we supported a study where a research team conducted interviews with members of the Black and African American community and asked about barriers to participation in research, why they may have not participated in the past, and what would make it easier to participate in the future. You can see here that you do get mistrust, again, as a reason for not participating in research. And you also see a number of other reasons, some that are ones that we can more practically address. So it's things like limited recruitment efforts. In this study, we had individuals saying, I've never participated in a research study because my doctor has never asked me to be part of a research study. So that to us is a cue to train all of our sites that are part of our research efforts that they should be asking all of their patients that they see in the clinic about participation in research, not just their potentially biased opinion on who may or may not be interested. So that was one really important finding. We also heard about the financial burdens, and that for us was a cue to make sure that all of our studies are compensating participants for any time spent at a research site, and that we pay for transportation to and from and for a hotel stay if it's a more extensive study that would require a long day in a doctor's office. And then the last one I'll highlight here is the digital divide, so lack of reliable access to the internet. Many research studies today may require you to start off by filling out a survey online. In fact, I'll talk to you later today about how to participate in a study that can start with signing up online. So to make sure that we can be inclusive in our recruitment for studies, there need to be options for offline participation and outreach that happens outside of the online mechanisms so that you are not only reaching people who have reliable access to internet, but are casting a much wider and more diverse net. Next slide, please. So why should you participate in research? As I mentioned, because we know that Black folks are underrepresented in research, that means that the insights that may be coming out of the current research studies are not including the Black experience with Parkinson's disease. We are getting a skewed picture of what Parkinson's looks like, and that is not setting us up for success when we think about the idea that we must have treatments that are accessible to all. We need to ensure that new therapies for Parkinson's work for all people with Parkinson's, and that means we must include diverse populations in research, and we must be inviting those folks with diverse backgrounds into our research studies. Parkinson's can impact anybody, regardless of race or backgrounds. It is not an old white man's disease as it is often thought of. Lack of representation has ethical and research consequences. So ethical consequences, because it is simply not right to be excluding individuals of all backgrounds from your studies. And then research consequences, as I mentioned, you're not getting the full picture of Parkinson's disease if you don't have adequate representation from all races and ethnicities. And then when thinking about trials that may be testing the impact of therapies that could treat Parkinson's disease, you must have adequate numbers of people across races and ethnicities in those trials to make sure that you know how every demographic will interact or react to the particular trial. If you only test a drug in white people, you cannot be confident that it will have the same effect on other races and other ethnicities. Next slide, please. So another poll, just to take the temperature in the room, how have you ever participated in a clinical research study? Maybe some of you are in something like All of Us. Maybe your doctor has asked you to be part of a study, or maybe you've never been a part of a study, but hopefully you'll walk away from this presentation with the desire to raise your hand to participate in research. Okay, we've got a mixed bag, mostly no's, but we've got some yeses, and we've got Tyrone, who's done this many times. Excellent. Next slide, please. So next, I wanted to talk about what MJFF is doing to work towards more equitable research. We are funding research in 3 different categories that support diversity, equity, and inclusion in Parkinson's disease research. The first bucket is around advancing globally relevant understanding of disease. And we are primarily doing this through a program called the Global Parkinson's Genetics Program. I won't talk about this program, GP2 for short, too much in detail today, but I will say that the goal of GP2 is to redefine the genetic understanding of Parkinson's and to make that understanding globally relevant. To get to that goal, GP2 is bringing together genetic information from 150,000 people with Parkinson's across the globe. And the goal is that at least 1/3 of those people with Parkinson's, so 50,000 people, will come from underrepresented populations across various regions in the worldwide spectrum. So again, I won't talk too much about this today, but there is information on the Michael J. Fox Foundation website if that's something that piques your interest, or you can feel free to contact us following the webinar. The second bucket of research we're supporting here is around understanding and addressing barriers to research participation. This we are moving forward through 2 studies that I'll talk to you about in more detail, the Black PD study and the Parkinson's Progression Markers Initiative, or PPMI for short. And then the final bucket is around understanding health and healthcare disparities. We've touched on that a little bit today. I won't go into that any further, but again, happy to take questions following the webinar if that's another area of interest. Next slide, please. So first wanted to highlight the study called the Black and African American Connections to Parkinson's Disease Study, or Black PD for short. Black PD is a foundational study of Parkinson's disease genetics in the Black community. It is critically important because the impact of genetics on Parkinson's susceptibility in the Black and African American population is largely unknown. 90% of studies in Parkinson's disease genetics have been done in only individuals of Northern European ancestry. And as you can see on this slide here, there are very few published studies that are looking at the genetics of Parkinson's in the Black community. And that again gets back to our concept of you are not getting the full picture of Parkinson's if you are not adequately studying all populations. Black PD is aiming to change this by establishing a foundational cohort to assess genetics in this population. In the pilot phase of Black PD, which we are currently in and will be in through the end of 2023, Black PD is aiming to enroll 600 participants across 6 clinical sites. And what enrollment looks like here is a brief one-time visit with a study doctor where you donate a blood or a saliva sample that is then used to extract DNA. And you provide some information about your medical history and family history. The study team then sends that DNA sample off to be analyzed, and you have the opportunity to receive genetic testing and genetic counseling if you are part of the study and have Parkinson's disease. So Black PD is just at 6 sites for now, and I'll share what those 6 sites are on the next slide, but can also share that the study will expand further in later 2023 and beyond. Next slide, please. So here you can see, I know it's a little bit small, but I'll read them to you. The 6 sites that are recruiting for Black PD. There are 2 in the Chicago area, one at Rush University and one at the University of Chicago. We are working with the Kaiser Permanente in the Mid-Atlantic. We are working with the University of Alabama at Birmingham, the University of Florida in Gainesville, and Louisiana State University in Shreveport. So if you or someone you know is located in one of these cities or near one of these academic institutions and you're interested in raising your hand to be part of Black PD, you can get started today at the website listed here, www.blackpd.org. Next slide, please. And the other research participation opportunity I wanted to share with you all is the Parkinson's Progression Markers Initiative, or PPMI for short. PPMI is our landmark study to define Parkinson's risk, onset, and progression. PPMI is a natural history study, which means we are not testing a new drug in PPMI. Instead, we are enrolling individuals and collecting information from them over time so we can understand what Parkinson's looks like over time. And the reason we're collecting that information is with the goal of identifying markers of progression for use in clinical trials. So breaking that down a little bit, let me first explain what a marker or a biomarker is. A biomarker is a biologic sign or substance that can be objectively measured and can tell you about the presence or absence of a disease, the risk for a disease, or how a disease is changing over time. A great example of a biomarker is cholesterol for heart disease. Cholesterol can be objectively measured. The level of cholesterol that an individual has can tell you if they are at risk for heart disease, if they have heart disease already, or if they do not have heart disease. And if you measure cholesterol over time and give somebody treatments or lifestyle changes to bring their cholesterol down, that will tell you how somebody's heart disease may be progressing or their risk may be changing over time. Very concrete, can tell you very definitively what's going on inside somebody's body. As we talked about in that slide with the DAT scan, the imaging results, we don't have a very reliable biomarker for Parkinson's disease for use in clinical trials. We are still diagnosing Parkinson's disease through observation of clinical symptoms. And what that means is that you can't be sure that the people that are enrolled in a Parkinson's disease study definitely have Parkinson's disease. And that means you may be diluting your ability to see if a disease is, if an intervention is treating the disease, the underlying causes of disease. And it means that if you have an interventional study where you are testing a new therapy for Parkinson's, you don't really know what to look at to see if your therapy is slowing or stopping the progression of the disease, because again, you don't have that objective measure that you can reliably measure in an individual. So we need better biomarkers, and particularly biomarkers that can measure the progression of Parkinson's disease to help make clinical trials more precise, faster, cheaper, and smarter. So back to PPMI, we are collecting data and biosamples from participants with, without, and at risk for Parkinson's over 5 years. We're looking to enroll about 4,000 volunteers at 50 plus global clinical sites in 12 countries. On top of these 4,000 volunteers, we're enrolling additional participants online for online and remote data collection. And the data are made available de-identified to the research community so that they can analyze the data to try to find these better biomarkers for Parkinson's progression that we're looking for. Next slide, please. We like to say there's something for everyone in PPMI. I won't go through this slide in too much detail, but I will direct you all to please check out www.michaeljfox.org/PPMI. When you get there, you will see what I have here on the screen, and it will tell you, depending on your individual characteristics, what you may be eligible to do in PPMI. Most folks on this call, I am guessing, will fall into this age 60 plus without Parkinson's disease section. For folks who are over the age of 60 without Parkinson's disease, we are asking individuals in this category to take a scratch and sniff smell test that comes in the mail. As I mentioned previously, there is a link between loss of smell and elevated risk for Parkinson's, and we think it may be an early symptom of Parkinson's disease. And by studying individuals who are over the age of 60 and don't have Parkinson's and who have loss of smell, there is a ton we can learn about how to predict who goes on to get Parkinson's and who doesn't, which will be very helpful information when we are looking towards how can we prevent Parkinson's disease onset in the future. Next slide, please. Okay, so we've got a lovely video that will take a couple of minutes to show. While my colleague Maddie is pulling this video up, I will just mention that in PPMI, we are highly invested in engaging diverse groups of individuals in the study and are proactively reaching out to communities that focus on healthy aging in different inclusive communities, which is one of the reasons why I was incredibly excited to chat with this group today.
Hey, I'm Akbar Bajabiamila. You may know me from my football days or recognize my voice from American Ninja Warrior or The Talk. I'm also the son of a father who has Parkinson's. My dad was diagnosed in 1999. At the time, I couldn't believe that my dad could have Parkinson's. I didn't know anyone in my big family who had the disease. I had barely heard the word Parkinson's before. Parkinson's is a brain disease that gets worse over time. Most folks associate the disease with shaky hands, but really, the disease goes far beyond tremor. It can cause walking and balance issues, constipation, depression, and thinking problems. Since my dad's diagnosis, it's been so important to my family to learn as much as possible in order to tackle Parkinson's head on. So, I joined the board of directors at the Michael J. Fox Foundation. I've been fundraising for research and attending educational events. Getting involved has given me and my family hope, and it's a different sort of way to support my dad. I've learned so much during this time, but there's one thing I still wonder about. Since my dad has Parkinson's, does that mean I'll get it? In my conversations with others in the community, I found it's completely normal to be worried about this. Let me share with you what the experts have told me. Having a blood relative with Parkinson's does slightly increase your risk of the disease, but it does not guarantee you'll get it. Having this family connection just makes you possibly more at risk for Parkinson's. That's because there are many factors that play a role in what causes Parkinson's. Today, scientists are learning more about why someone gets Parkinson's. But the truth is, we need more data. We need more research volunteers. And it's important that research includes representations from all communities so we can help scientists better understand this disease. You have an opportunity to help the smartest minds find better treatments for Parkinson's, and hopefully someday soon, a way to prevent this disease from ever happening. Get involved.
Thanks for pulling up the video, Maddie. So wonderful words from Akbar of encouragement to raise your hand to participate in research, and really the importance of involving members of the Black community in our studies. And with that, I've got one more slide and one more poll, and then happy to take questions. So the last slide before our final poll question is where you can go to learn more and get involved. So we've got links on this slide here, and the slides will be distributed following the webinar. If you're looking for more information about Parkinson's for yourself or for a loved one, you can download our Parkinson's 360 guide for navigating Parkinson's disease. Find a movement disorder specialist to get access to the best treatment possible, and download our Navigating Clinical Trials guide, which is a guide for Parkinson's patients and families on what it looks like to be involved in research. And then I'm also hoping that many of you do raise your hand to participate in research. If you're located near one of our Black PD sites, you can contact one of the sites at blackpd.org. And then you can also join the PPMI Smell Test Challenge at the link listed here. Again, critically important for us to be studying diverse groups of individuals over the age of 60 to learn more about the link between loss of smell and risk for Parkinson's disease. And it is as easy to start as filling out a scratch and sniff test from the comfort of your own home. And if that is not enough for you, you can look at lots more research participation opportunities on our Fox Trial Finder clinical trial matching tool, also linked here. So we'll wrap up with our final poll question, and then I'm excited to hear questions that you have for me. Following the information that you've received today, would you consider participating in a clinical research study like Black PD or PPMI? Got Valerie coming in strong with a yes, lots more yeses, Angie and Angela. Tyrone, our clinical research veteran, great. Cynthia still on the fence, that's okay. You don't have to make all your decisions today. There's lots more information out there if you still have questions or hesitations. Thanks everybody for your candor and for your attention today, and glad to open it up to hear what questions you may have for me. Oh yes, and following this talk, if you did not get to ask your question, you can contact the NCBA folks, or you can contact my colleague Maddie directly. Their contact information is on this slide. Thank you.
Thank you, Alyssa, and thank you very much to you and Maddie for joining us this afternoon. What a thoughtful presentation, and my thanks to all of you, Maddie, and your colleagues at the Michael J. Fox Foundation. We have a few questions in the chat, and I'd like to share those with you if I can and kick us off. One of the questions asks, do employers offer paid time off to participate in research studies? And are research studies conducted on weekends?
So for the first part of that question, it is employer dependent. So I unfortunately can't give a specific answer to that. It would really be at the discretion of the employer what they will or will not offer paid time off for. And for the second part of the question, are research visits available on weekends? This depends on the clinic, but it is something that we strongly recommend to our research sites that we fund or sponsor, that particularly if they are doing community outreach into diverse communities, that they either have a day available on the weekend or an evening appointment to help accommodate people who cannot take off from work to be part of a study.
Okay, thank you. The next question asks, do the motor and non-motor symptoms of Parkinson's disease look similar in men and women?
They do look similar in men and women. The slight difference that we see between men and women as it relates to Parkinson's disease is that it does look like it affects slightly more men than it does affect women, but the presentation between men and women is pretty much the same.
Okay, thank you. Next question. Alzheimer's disease, dementia, and Parkinson's all are neurodegenerative diseases. What are the differences and/or similarities?
Sure. So I'll start with the differences on sort of the biological level, and then I'll talk about the differences on the symptom level. On the biological level, they are both diseases that we believe are caused by the abnormal clumping of protein in the brain. The difference is that for Parkinson's disease, there is abnormal dysfunction of one protein. It's a protein called alpha-synuclein. For Alzheimer's disease, it's a clumping of two different proteins called A-beta and tau. So they're both caused, we think, by issues with protein clumping, but we've got different proteins in play. And then on the symptom level, Parkinson's disease is typically characterized by the motor dysfunction, although as we discussed, there are non-motor symptoms as well, whereas Alzheimer's disease is characterized by problems with memory and thinking. There is often what we call co-pathology. So as somebody's disease progresses, maybe they have started with the problems with the Parkinson's protein, but over time they may also develop issues with the Alzheimer's proteins in their brain. And then that can lead to instances where you can see both the Parkinson's disease motor type symptoms and the memory and thinking more classical Alzheimer's disease symptoms. But that's the main difference, the protein level and the movement dysregulation versus the memory and thinking dysregulation.
Okay, thank you. And Alyssa, it looks like we have time for one more question, and we thank you for answering the questions we didn't get to today. The last question reads, can you please give an example of what one of the research studies involves? What will I be asked to do?
Sure. So maybe I'll give both the Black PD example and the PPMI smell test challenge example. For the Black PD example, what you'll be asked to do is you will come into one of the research sites and you'll spend a couple of hours, maybe an hour or 2 hours with the study doctor and the study coordinator. They will collect information about you on your medical history and your family history. And they may also do a brief exam that looks at the motor symptoms, whether you have Parkinson's disease or not. And they will collect a blood sample. And that's the blood sample that will be used to isolate your DNA and generate your genetic results. For the PPMI smell test challenge, what that will look like is starting by filling out an online questionnaire that confirms that you are over the age of 60, do not have Parkinson's, and are located in the US or Canada. And if you are eligible based on those criteria, it will then collect your address so that we can actually ship you that smell test. And then once you get the smell test, what that will look like is on your own time, whenever you like, you'll take the test, you'll scratch it off, you'll give it a sniff, and then you'll record what it's a multiple choice of what you think the scent might be. You'll enter those scents, your answers to the scratch and sniff smell test online. And if you have loss of smell, then you may be contacted to then come into one of our clinical sites for further evaluation. That evaluation would look like an imaging scan. It's actually the DAT scan that we had a picture of earlier in the presentation, and the same types of questionnaires, potentially a blood draw, other sample collections, again, depending on your results of the smell test.
Thank you, Alyssa. Thank you. Thank you. We are exactly at 2:01, and I want to respect yours and Maddie's time. And again, thank you for joining us. We hope you will join us again. And to our audience, thank you for joining us and for your awesome questions. And we give you back your day.
Thank you so much, everybody.
Thank
Thanks,
you.
everyone.
Bye-bye.